Okay, thank you everyone for joining us today. Before we start, we wish to acknowledge the land on which the Toronto Office of Canadian Scholars operates. Since time immemorial, this land has been the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabes, the Haudenosaunee, and the Huron-Wendat. Toronto is under the dish with one spoon treaty in which all Indigenous, First Nations, Inuit, and Métis people, along with all newcomers to Turtle Island, have been invited to share and protect the land in the spirit of peace, friendship, and respect. Hello and welcome. Thank you all for joining us today. This is a virtual event celebrating the publication of a critical mental health primer towards informed choice in social services, education, and healthcare. I'm excited to be here with you all, and in just a few moments, we'll be hearing from the author of this book, Dr. Jan-Ann DeFehr, followed by her colleague, Dr. Ameil Joseph, our book launch discussion facilitator. Jan DeFehr is an associate professor in the Faculty of Education at the University of Winnipeg. Informed by her previous clinical social work practitioner experience, Jan's course development, teaching, and research builds public access to the peer-reviewed, scientific, anti-colonial, and ethical critique of mental health premises and practices that has been produced by users and survivors of psychiatry, academics, and professionals. Jan is an associate of the Taos Institute and has collaborated with the Cananquil Institute in Merida, Mexico since 2004. She received her MSW from the University of Manitoba and PhD in Social and Behavioral Sciences from Tilburg University in the Netherlands. Ameil Joseph is an associate professor in the School of Social Work at McMaster University. He works with contributions from the perspectives of critical mental health, post-colonial theory, critical race theory, and critical disability studies to study the historical production of ideas about difference, normalcy, sexuality, eugenics, race, ability, and mental illness as they cohere, diverge, interdepend, perform within policy, law, and practice. His work is informed by over a decade of experience in the mental health field, in supportive housing, settlement, crisis respite, forensic assertive community treatment, community-based early intervention, and governance settings. Quickly before I hand things over to our speakers, I want to mention that we have a discount code available, as you can see on the screen here. It is CMHP25, and this will give you 20% off any purchase made on the Canadian Scholars website, and this will be available for use up until June 16th, 2025. We encourage you to take advantage of this great discount available. I will also be taking any questions from the audience at the end of the presentation, so please feel free to use the question and answer function through Zoom. There's a Q&A button at the bottom of your screen, and you may submit your questions at any time during this presentation. I would also like to mention that this webinar will be recorded and emailed to all who registered in the next few days. Also, we'll be giving away 2 copies of the book to attendees who will be contacted after the launch. Now I invite Jan and Ameil to deliver their line acknowledgements, and I'm just going to pass the screen over to them.
I guess I'll go ahead. We didn't discuss any kind of order here, but I want to echo Soni's welcome to this gathering and my thanks to everybody for being here, to my colleague, Dr. Ameil Joseph, and Soni BK from Scholars Press, or sorry, from Canadian Scholars. And of course, thanks to the publisher for the opportunity to publish this book. I live and work on Treaty 1 territory and the national homeland of the Red River Métis in Winnipeg, Manitou Abbey, known also as Winnipeg, Manitoba. These are the ancestral lands of the Anishinaabe, Sininu, Ininewek, Nehethawak, Otishakoan, Dakota, Oyet, and Michif peoples. Our water is sourced from Shoal Lake 40 First Nation in Treaty 3 territory, and most of our hydroelectricity comes from Treaty 5 territory in northern Manitoba. For colonial white settlers such as myself, land acknowledgement must involve direct contribution to Indigenous-led land back and land defense work, perhaps now especially and in the next months and years to come. Not as charity, but as our minimal duty.
Thank you. I'm happy to be here too. I'm participating from these lands we call Hamilton at McMaster University. I'm in the house that we have at the Office of Community Engagement here, and these are traditional territories of the Mississauga and Haudenosaunee Nations. The land's also protected by the Dish with One Spoon Wampum Agreement. Feel like this book does a lot of grounding, and I think all of us from our different places, different places of being, different places of experience and analysis, we'll have our own takes on this, and I'm happy to discuss it with you. So I'm happy to be here. I was thinking to myself, you know, I never had anything close to this in undergrad. I think the first exposure to anything critical when I was doing undergrad at the University of Waterloo was in a psychology course. There was one week where the instructor offered a kind of critical perspective on big pharma and psychotropic medications. And he brought up a book, Listening in Prozac, which was written many years ago, and the idea of kind of fudging the numbers and flipping molecules and to kind of like exploit a patent for as long as possible. And it wasn't until much later that I sort of had a confluence of collisions with exposures to pieces of the mental health system. I started with an organization called Waterloo Regional Homes for Mental Health, which is now called Threshold. Uh, and it was, and I didn't really put it together at the time, an alternative that was trying to keep people away from traditional psychiatric systems and crisis services and policing and uh, by building community, by having people care and live together in communities as part of community and making community as healing, as response to need. And then I got to see every other piece of this system, from ACT teams to early intervention teams to inpatient settings. And it was the kind of experience that helped me really see the contours of uh, you know, punitive carceral penal logics inside of mental health systems, services, practices, policy, and law, and the need for complex critical analysis that you provided here. We're grateful to have read it. I'm glad that it exists. And I was thinking like, this could be a course on its own for sure. And I feel like the way it was organized, like I was pleased with the accessibility of the book. The way it is so organized and detailed contents, the clear headings, the post-chapter invitations, the index. You engaged complexity with care and made it powerful yet discernible. Just wondering if that was intentional in the design of itself. And as you tell us a little bit about that, when you start there.
Well, thank you for those comments about the book. They mean a lot to me. And I'm pleased if you found it accessible. Ultimately, I hope it gets used. And I appreciate your comments about how people will arrive at this text or not, but from various locations in relation to the mental health system. And I realize that many people bring really strong feelings and convictions, opinions, to the topics that we'll be discussing and to the topics discussed in the book. And there is a tremendous amount of, well, what's a better word than dissensus? Disagreement in the field. And so I hope that readers feel well cared for when they encounter the text. I have not wanted to smooth over the criticisms or I don't know, minimize them. And at the same time, I don't want to be unnecessarily provocative. I want to be critical, but also constructive with my writing. And so, more than anything, I hope that the book will help improve autonomy, liberation, dignity, choice for people as they relate to a massive system of the colonial state, the mental health system.
Mm. Yeah, reflecting on what I just shared in terms of like, my own ways of telling a story about how I've come to be quote aware of the need for critical perspectives and how I can come at that in many angles. I could come at that from experiencing, psychosis at a young age and being tied down to beds or being interrogated, waking up as a young teenager in a hospital bed and being asked questions by a social worker about me and my family that I was in no condition to be answering at the time. Uh, I think you know, often talk about myself as a Canadian born Guyanese of South Asian descent, someone who was descendant of indentured laborers brought to Guyana to toil in some of these sugar plantations under colonial rule. And losing place and language and religion, and when I say losing, literally beaten and taken from us. And how, suicide rates in Guyana are some of the highest on the planet. Uh, there are so many ways that we can kind of come into this, or that we're enveloped in uh, the size systems that you tear apart in this book. That first line in the field of mental health is a way of folding people into itself without their noticing. And for me, that sets the stage for the entire book. Maybe even tell us a little bit about that.
Okay, well, I guess some thoughts that I had as I was writing that part of the book. Yeah, the field of mental health has a way of folding people into itself without their noticing. I think of that phenomena of folding, if you want to say, as an issue of transparency and fairness, procedural transparency and fairness. So for members of the public, if you want to say, or like all of us, people generally don't understand where the mental health system exists in the community. Many decades ago, psychiatry expanded to produce its field of mental health, as you know. And so it's a multidisciplinary field. And so people aren't necessarily sure where the mental health professional is, or who is the mental health professional, who has authority from the state to assign or to assign a mental health or mental disorder diagnosis, or initiate a mental health assessment. So I've routinely heard from people in my years of social work practice and in my years of teaching this course content that people were surprised to pick up a diagnosis or three. They were just speaking with a family physician at a brief appointment and, disclosing some distress related to maybe housing insecurity or, some other kind of human worry. And that was the entryway for them into the mental health system. They didn't necessarily choose that. Some people will have welcomed it, and some people will have asked for assessment, but the system as we have it is based on implied consent. So that if you show up as the client in the office of a mental health professional, and one that's authorized to assign a diagnostic label from the manual of diagnostic labels, the assumption is that you have consented to mental disorder assessment, mental health assessment, whatever you want to call it, and any number of diagnoses that can result from that. So part of my concern in writing that opening line, and also just in writing the book that follows, is I guess the concern is about consent. And if we don't have the information we need to offer authentic consent to various interventions and forms of support, then we're receiving a non-consensual service, and a system that depends on our uninformed consent is delivering a non-consensual service. So it's an ethical issue, and it's going to impact certain groups differently. Yeah, maybe that's all I need to say at this point.
Mm-hmm. It is a disturbing kind of experience to be in a position of, say, putting in a social work program with some new letters and an amount of power and authority to craft somebody else's story in such a way that channels, historical eugenic colonial discourses that were designed for nation building purposes and for sorting types and kinds of people, and watching it play out so easily. I felt that, there are moments where you learn how to write the kind of thing that goes into the box of an ODSP application that makes someone sound in need enough and pathologizes them in such a way that it is so deterministic, and as you exposed, alludes to some biomedical hegemony that has never existed. I mean, the kind of biomarkers that we allude to not existing. The hegemony definitely exists, but the allusion to these things that we never needed to prove or defend, that no one questioned, and we have no good reason to do it. Yet that practice allows for the kind of neglect to occur, the ethical breaches, and the ways that the idea of consent is tossed about inside of coercion and omission. I feel like that some of those pieces of analysis come to me from the areas that were all up in the bio that was read earlier. But very often, mad studies and perspectives in critical mental health, and a lot of the critical disciplines that we talk about as fugitive disciplines, things we smuggled into the university to try and change it, Black studies, mad studies, gender studies, feminist studies. We learned how to wield story and experience and history for a kind of epistemic transgression, for impact and transformation. And I was struck by how all of that is in here too. the use of experience and story and history. And I don't know your thoughts on why you think that is, why you think it's important and useful.
Well, correct me if you think I'm not understanding the question correctly, but um, yeah, I'm really concerned about that kind of moment that you've described at the very beginning of your comments just now, where you were saying just so easily and effortlessly, um, professionals who have been granted a lot of power take somebody's story. Often it's a story about distress or difference or something that's perplexing, perhaps some perplexing or problematic behavior. And it's taken by the professional, and within the mental health system it's um, pathologized, even though, as you've said, we don't have scientifically valid biomarker evidence of pathology, or if you want to say disease or illness, for any mental illness diagnosis, except for like a small handful that have been thrown into the DSM. We're not exactly sure why they're there. They're primarily studied in other disciplines, like the example of sleep apnea or some of the dementias that are mentioned in the diagnostic manual. But primarily, the diagnoses by far are about pathologizing human experience without evidence of pathology. And in pathologizing that experience, we individualize human struggle, we decontextualize it, we depoliticize people's experiences. The movement called, their acronym is ERNI, ERNI, emotions are not illnesses. They speak about that process of taking the story offered by another person and, pathologizing, psychiatrizing it as identity theft. And I found that a lot of the anti-colonial critique of mental health premises and practices is about examining those practices of dispossession, that this is an experience and feelings or behaviors that belong to people individually and collectively. And when professionals move in and non-consensually, take that human experience and place it into the psychiatric register. Yeah, it's problematic. And when people get access to the content in the critical mental health scholarship, and also they can contribute to that knowledge as well from their own experience, it's not just a one-way flow of information or knowledge, then they're better positioned to make informed choices in relation to the mental health system. Where do I want to seek help in times of overwhelming difficulty? Yeah.
I think, like we've been talking about, people have and have for generations had critical perspectives, critical takes on the unjust, violent operations of society, industries, and institutions. And sometimes it takes, a beacon to kind of signal that it's okay to be critical, and that this is how we can do so together. When you talk about mutual aid, and knowledge sharing being fundamental to it. I think there's ways that we can talk about how we inherit and craft it and honor those who've come before us, and to carry on that work as a part of liberation and solidarity and struggle, like, is part of the work that is kind of very different from the idea that people are in a vacuum without knowledge and they need critical knowledge to be, I don't know, in them to be critical. It's kind of like, no, that's not this. This is honoring all the work that's been done before and a way of, lighting the beacon for more of it to be okay to be said and named, so that it can continue. I think, if we can make it mandatory reading for students in social work to kind of confront their complicities historically, whether they consent to it or not, whether they're being folded in or not, also without their consent, such that they can be something else rather than, interlocutor with giant size systems that continue to do harm. And, there's a page in here on page 80 where you talk about Corey Charles Cardinal and the abolitionist prison protest and the actions. So when you think about that word, abolition, the lessons and struggles of abolitionists, and then that and critical mental health movements, how do you think about, this book, the work in it and through it as aiding in those struggles?
I'm laughing a little bit because I remember writing to you. Feel free to ask any question that comes up for you that we haven't discussed in advance. And now I regret that you took me up. No, I don't regret. But for myself personally, I'm an abolitionist around so many, in relation to so many state systems, including psychiatry. Because I think we've always had other ways of supporting each other. I think we have better ways of supporting ourselves and each other without depending on a system who perpetuates so much misinformation and harm. At the same time, I don't think I've put forward an abolitionist perspective here. The subtitle says towards informed choice in social services. So even though I feel like burn it down, we don't need it, I feel like there will, well, not I feel like, I am aware that there will be many, many out there who say, my diagnosis, for example, someone might say my diagnosis of autism spectrum disorder is important to me and it makes sense for me. It's useful for me. People might not be aware that autism spectrum disorder, ASD, is one of the diagnoses in DSM-5, the diagnostic manual. And so I feel like it's not up to me to say, to tell other people what's helpful for them or what they should leave behind or be critical of. So more so, I wanted to try to synthesize and perhaps expand the bodies of critique that I've been engaging with. Of course, I left so many out. I realized the more I wrote, the more I realized I wasn't writing about. But yeah, I feel like ultimately, I want to respect the dignity that is inherent in informed choice, given the systems that are in place at this time. I feel like an informed choice stance is kind of where I want to be, even though personally, I don't agree with the idea of putting psychiatric labels, which are permanent and cannot be undone, on children, adolescents, young people, and people of all ages.
I think, the idea of choice is in of itself the same kind of discursive black hole as consent. And you have kind of benevolent, benevolent, aspiring, innocent making professions like social work using those words to do the opposite things. And, in a biomedical hegemony, choice becomes, I intervene biomedically, you're non-compliant, or that didn't work. And it escalates in biological intervention that includes biological harm, that includes restraint and, ECT and kind of physical interventions that begin from a premise that assumes that you're a broken animal, and that's where the intervention lies. That idea of choice is a false one, where you only can choose within the range of possibilities inside of a particular paradigm that omits and excludes social, historical, and political contexts. Anything about it, the infinite uniqueness of an individual, and beginning from an acknowledgement of distress and suffering, which you say is a good starting point. We can begin there as people acknowledging suffering and need. I gotta say, I got a little hung up on you know thinking about the ways that social work um, has some individual focuses as well, and you're bringing up things like narrative therapy and solution focused perspectives as possibilities for alternatives. Yet those two are black holes that now have been historically imbricated in psi dominant practices that bring forward into those narratives biomedical hegemonic discourses, racialized discourses, ableist and sameness discourses inside of ideas of solution, inside of ideas of therapy and care. And given all that, given those complicities, do you believe that those can still be salvaged, or what are we to do with them?
Yeah, I included narrative and solution focused in the chapter that looks at non-pathologizing approaches to care,
Mhm.
and also included peer-based work. Yeah, a number of examples of that as well. But I included narrative and solution focused because their origins began outside of psychiatry as a critique, like explicitly rooted in critique of psychiatry and mental health premises and practices.
Mhm.
So they declared themselves initially, at least their founders did, as non-pathologizing. But I think that I totally agree, if this is what you're saying, is that we can find all kinds of um, instances where those traditions of practice have also been co-opted into the dominant pathologizing paradigm. So at the end of that section, I offer words of caution for all professionals, regardless of the community of practice that they might identify with. That just the role of the professional itself can set a person up to, I don't know, in some kind of superior position. Yeah, it's so much easier to have, wisdom around other people's dilemmas, and our own struggles can seem so much more complicated. So, yeah. Do you want to say more about that?
No, your answer was great. Sometimes, despair, like uh, some things just have to go. And it sometimes forecloses on the idea of like imagining possibilities that are still maybe there, or how I think about something that is called narrative therapy, or how I think about people like Bell Hooks and Derek Bell, who are exemplary in terms of how they helped us understand the kind of transgressional impact of story and story as a way to intervene on dominant discourses and systems of oppression
Mm.
as a place for imagining new possibilities. And my earlier question about story and experience and history uh, is something that's sort of key to fields that contribute to how we know about critical perspectives and about anti-colonial, critical race, the critiques of societal patriarchy and neoliberalism and colonial capitalism and ableism and Satanism and eugenics and mad studies and critical disability studies, at least these disciplines that have given us other places outside of experience uh, and places inside of experience to tell stories. Um, I think there's something to it, is what I'm trying to get at. That,
Okay.
when we recognize our complicities as authors of ethical transgressions, then, it is the story making that becomes the violence when crafting, arguments for a biomarker where there is none, et cetera, and rationalizing violence that is occurring through psych meds and so forth. But unstorying via a real story of experience is the kind of critical uh, anchor, I think, for much of what we were talking about. I know we probably have like, I don't know, 9 minutes, 8 minutes or so. I wanted to ask you if there's a passage that you wrote that you want to share with us. It could be something that came out of, I don't know, when I write, it's kind of like, I surprise myself. Sometimes a paragraph comes out and you're like, oh, right, that's it.
Uh-huh.
Something like that in the writing process, or something attached to a moment, or a story of yours that you want to take, that you want to share.
Um, Thank you. I wrote down a number of possibilities, and I think I might choose one or two brief ones. Um, I did realize as I was revisiting the primer now on the other side of it and seeing it in print, um, as I was writing about how institutions have ways of resisting transformative and liberatory change. I experienced instances of that, you know, um, of suppression um, and threats to my academic freedom. Uh, yeah, as I was drawing on Sarah Ahmed's work to write about how institutions can use progressive policies to suppress um, critical knowledge mobilization. So I thought about reading from that portion, but I feel like that's maybe a bit too much for us this afternoon. Um, Perhaps I could read a little bit from the section where I'm critical of informed consent policy on page 173. Um, I've considered the shortcomings of professional ethics guidelines. Here I am writing at the end of the chapter, noting that the same associations that produce them are fully implicated in the scientific and ethical controversy that has plagued the mental health system since its inception. These same professional associations write about full disclosure, in other words, the obligation to disclose any knowledge related to potential for harm, Yet very few associations model the standard they describe. This chapter has therefore argued for a more public informed consent ethic, one intended to enable choice rather than mere consent. Since members of the public rarely gain access to critical mental health knowledge, I suggest our critical knowledge mobilization must move beyond the soundproofed professional office into the waiting room, the boardroom, the organization's website, the broader community. Community members are entitled to full disclosure before they enter the built-in diagnostic opportunity in diagnostician offices and exam rooms. Administrations, associations, university senates, departmental curriculum committees, regulatory bodies, and other authorities must join ethical practitioners in creating and protecting conditions for informed choice. Colleges of physicians and surgeons, created with the protection of the public declared as their uppermost purpose, must take responsibility for enabling a shift towards informed choice within the mental health system. This new agenda would entail making reparations for harm done as well. And I'm just going to skip to the last sentence. What must we do with the critical mental health knowledge that derives from patients, ex-patients, survivors of psychiatry, scholars, and professionals? We must share it fully, respectfully, and compassionately, that is, publicly. And do you think I can share one more portion?
Yeah, absolutely.
Do you want to raise a comment or concern or criticism, or before I do so, or should I just go ahead?
No, go ahead.
This is at the end of the book. The multiple points of entry into the mental health system will differ within each unique institutional or organizational setting. The task of the hour, as I see it, is this: go to each entry point and build public access to critical mental health knowledge. And I would say, I want to pause to say that includes the anti-colonial critique of mental health premises and practices, which, we could only hint at, I think, or begin to get into in the amount of time that we had today. Demand informed choice practices, policies, resources. Create informed choice coalitions and networks. Host informed choice learning forums that engage with the long-standing critique of psychiatry and its field of mental health. Notice the systemic entanglements and captivities perpetuated by colonial state systems, and take action to address root causes of human suffering. Talk openly about the words of child and adolescent psychiatrist Sami Timimi, which echo throughout the critical mental health literature. And these are his words: mental health services are not always good for you. There are some troubling facts to confront. End of quote. The informed choice standard of care requires public disclosure, and this collective disclosure work, like all liberatory world making, helps set us free. So yeah, the statement about mental health services not always being good for us. Of course, for many people, it has been really beneficial to seek support within the mental health system. But others found that their diagnoses created difficulties for their professional licensure for several professional licenses, or blocked their access to disability insurance, or put them in a more expensive risk category, or, as you have written about in your 2015 book, about deportation and the confluence of violence within forensic mental health and immigration systems. A diagnosis can be used to strengthen somebody's deportation, or block their access to child custody, or, what can create difficulties for their adoption proceedings, whether they are a parent that needs to have their child adopted out, or they're people seeking adoption, that having an established mental health history can be weaponized against people in different circumstances throughout their lifetimes. And so this is one of the ways the colonial state, I guess, benefits from the pathologization of human distress. It kind of sends the message, it's you, it's faulty individuals that are the problem. Capitalism, colonization, ableism, all systems of oppression are not worth mentioning in so many mainstream mental health contexts. So,
Mhm. You you think about what I was alluding to before, those who have come before us and where we write from now, this book and right now and what's next. And I think about, Bill 6 in Ontario, which seeks to persecute people who live outside. You wielding discourses of, mental health and addiction with the very allusions to biomarkers that don't exist, to establish ideas of biological inferiority. And those are tied to, the kind of scientific racial technologies that we also have generations of critique about and know from. And the kind of history of eugenics that has scaffolded these professions and the ways they inserted themselves in laws to make themselves the kind of uh, orchestrators or authority figures of white supremacy. I feel like, wielding informed choice is an important intervention, and I'm appreciative of it. I think about the ways that it will be the kind of thing that I'm also worried about in terms of the backlash, when we write from these places that will occur, you know. I was reading the other day, Jasper, for the right to remain around disability justice in Palestine, and how a lot of these critical ways in are ways that are unifying solidarity building, not dividing, truth telling, and I think we need to do more of that. And like I said at the beginning, I'm grateful that this book exists. I think I was already scheming in kind of which parts to use in the course I teach, and then was thinking, what if I had a course based on this instead of, the kind of clinical interviewing course type thing you do in social work, where you talk about assessments and so forth, practice them and practice interviewing skills in these simulated and ridiculous ways. And rather than do any of that, falseness, the false performance of ethics, which are ethical transgressions, you would do something else. Practice just being honest and transparent and informative and supportive. Practice that first. Practice the critical. Yeah.
And be willing to say, we don't know why. We don't know why someone may be seeing things that others don't see, or perhaps tormented by voices that people can't sort out, or whatever. Like, to be willing to say, to recognize that we have a lot to learn and we don't know everything, and and to invite learning together with people and to support that. What can we do to be helpful? You mentioned backlash, and I think that that's part of your work as well. I'm just going to guess anybody that is doing work that shifts power or unsettles the usual, corridors of power, if you want to say, you will hear from you'll hear from those systems. Um, but we can take a lot of courage, and we can learn from the examples of so many people who've gone before us and who are caught up in struggles for liberation around the globe right now. So it's something that I appreciated about your work, Ameil, the sense that struggles for justice and liberation are interlocking, and it's important that we are informed by other movements and in solidarity with those movements as well.
Mhm.
And we have to carry on and do what we feel is the right thing.
My supervisor during my doctoral stage was Ameil Joseph, the late Amy Lester, who used to say to me, part of our job as people that hang around with discourses around social justice and critical is to keep doing it, to always think about who we've left out and how. And I feel like this book, even the title of it, Critical Mental Health Primer, is exactly that. Something that opens up and allows for critique to not only begin, but then proceed as a practice. I was happy to be invited to do this with you today. Um, so thank you for the book.
Thank you for your work. Thank you for your willingness to join today and to help facilitate this conversation. It means a great deal to me. And thanks again to Sony for being here too. I think you have some final comments.
Yes, thank you both for the wonderful conversation. I'm just going to jump in quickly to share a question from the audience and lovely remarks. I'll just read out the questions. They asked, what are the next steps for the book? When will universities and colleges have access to it? Who in general do you predict will be teaching it?
Okay, I'll try to remember those questions. Who in general will be teaching it? Really anybody. I have tried to write with people in social work, social services, education, and healthcare. Healthcare is a really health sciences. If you want to say, those are broad disciplinary areas, and those are all areas where mental health premises and practices are very powerful and active. So the book can support coursework in any of those areas. I think I've shared over 500 slides for people who purchase the book for use in teaching contexts. I think the book was primarily marketed to social work faculties, but I think that anybody could benefit from access to critical perspectives and also strategies around what can we do instead and how can we build that public access. So anybody can buy the book from Canadian Scholars. If you want to write to me, I'm so happy to be in touch with anybody who's interested in teaching this content. I have taught almost nothing but critical mental health courses, which I've created in conversation with others. Of course, since 2015, that's my main teaching and research area. So I'm so happy to hear from people who might want to veer down similar paths.
Thank you. And thank you everyone for your lovely comments. I will share the link for the book if you're interested. I'm also gonna share the discount code again so you can note it down before we end the webinar. Oh, here we go. So again, that's code CMHP25, and this will give you 20% off any purchases made on the Canadian Scholars website until June 16th, 2025. There will be more communication sent after the webinar with more information about the link, etc., as well as the recording. And finally, I want to thank everyone for attending today's webinar, and a special thanks to our speakers for bringing us such an important and meaningful conversation. I think we'll end this off here. If you guys have any closing remarks, please let me know. But thank you for attending the webinar again today, and I hope you all have a great rest of your day.
Many thanks.
Thank you.